Hello and welcome. Thank you for joining us today. My name is Karen Eggleston, and I serve as director of the Stanford Asia Health Policy Program. I am delighted to introduce our own postdoctoral fellow, Dr. Radhika Jain, as part of our webinar series exploring public and private roles in health, medicine, and longevity. The previous speaker in this series was Nobel laureate Oliver Hart, whose webinar and written lecture are available at our website. The next webinar in this series will be next Friday, March 5th, joint with Harvard Kennedy School on public-private collaboration in China and the US, with my co-authors and Yijia Jing, Dean and Professor at Fudan University, and Lawrence Summers, President Emeritus of Harvard University. There's also a webinar next Tuesday, March 2nd, on demographics and innovation in Asia. So we welcome you all for that if you're interested. Today, I'm delighted to introduce Radhika Jain, who is the current Asia Health Policy Postdoctoral Fellow at Shorenstein Asia Pacific Research Center. Her research focuses on healthcare markets, the effectiveness of public health policy, and gender disparities in health. She completed her doctorate in the Department of Global Health at Harvard University in 2019 before joining Stanford. Her research has been supported by grants from the Waste Family Fund and the Jameel Poverty Action Lab. She has worked on impact evaluations of health programs in India and other countries and has held a doctoral fellowship at the Center for Global Development. We will hear today about her innovative and careful empirical research on a vital issue in health policy: how to improve results when government programs contract with private providers for service delivery. Importantly, her work underscores the role of competition and market structure, a factor rarely taken into consideration in health policy in India and elsewhere. Radhika, welcome. We look forward to your presentation. Over to you.
Thanks a lot, Karen, for that introduction and for inviting me to the seminar. And thank you to whoever's watching this for joining us. So today I'm going to talk about private hospital behavior under government health insurance in India. And as Karen said, I'm a postdoc at Stanford. And I want to preface this talk by saying that a lot of what I'm going to talk, the material I'll cover today is part of a larger body of work with Pascaline Dupont, who's also a professor here at Stanford. So lower and middle income countries have been expanding public health insurance in order to meet the goals of universal health coverage, which is essentially ensuring access to high quality healthcare alongside financial protection to the entire population. In India, these programs have been scaled up since 2008 in various states. In 2018, the central government launched the PMJ health insurance program, which it aims to cover the poorest 40% of the Indian population, and had a budget of approximately $90 million in 2019. About this 75% of the spending under this program is in the private sector. So these insurance programs, across India have a sort of similar design. They target the poorest households. They focus on secondary and tertiary hospital care, so they don't cover primary care. They don't, they don't cover things like fevers or seeing a general physician, but going in for minor surgeries or childbirth or things like that. Under these programs, patients are entitled to entirely free care. This is precisely because they target the poorest households. Households are not expected to pay anything to the hospital for eligible services under the program. Healthcare under these insurance programs is delivered both through the large network of public hospitals in India as well as private hospitals. And these programs rely on a prospective payment system rather than a fee-for-service system to contain costs. And I'll come back to this. So just keying in on a couple of aspects of the design of these programs. So I said, that one part of these one important factor is that these programs contract the private sector for delivery of healthcare. So historically, Indian health policy has largely focused on direct public provision of healthcare through this large network of health centers and hospitals across the country. However, over the last decade, there's a lot of research that has come, as well as anecdotal evidence showing that the quality of care in the public sector is not good. Additionally, the public sector has been very hard to reform, in part due to political economy constraints. And there's research looking at this as well. And as a result, because of the sort of low quality of care in the public sector, people overwhelmingly turn to the private sector for hospital care. I think about 50% of all hospitalization is in the private sector, but at substantial financial cost to themselves. So under these new insurance programs, the idea is that, delivery through private agents, through private hospitals, can, and to some extent, leverage market mechanisms, competition and the profit incentive, and provide better care. And there is research that shows, for example, that the healthcare quality is better in the private sector than it is in the public sector. And in fact, that the same provider, same doctor, when he practices in public, provides worse quality care than when he practices in private. So that's what these programs are trying to leverage some of this. However, there's a big these are profit motivated agents, and they come with their own challenges in monitoring and incentivizing them. The second aspect of these programs that I want to focus a little bit on is the fact that they use prospective, or sometimes known as bundled payment systems. So what this is that instead of paying the hospital for everything that it bills, the hospital is paid a flat rate for a predefined service or visit or diagnosis. And this is a system that's used in Medicare in the US. And the idea is that by telling a hospital that they'll get a flat rate for a service, it encourages the hospital to do what it can to be more efficient in the provision of care, and therefore contain and it basically helps the government contain program costs. There's many of you might know about in the US, where there's fee-for-service payment systems. The healthcare costs burgeon because hospitals have no incentive to provide care more efficiently or cheaply. And so under these insurance programs in India, if they guarantee patients free care, they pay hospitals at these bundled payment systems. And so the idea is that it can reduce costs while providing financial protection. However, and the effectiveness of this system depends critically on the reimbursement rates. So now you are setting, essentially the government is setting fixed prices for each of the services that it's asking hospitals to deliver. And so how do you set those prices is a really, really important question. There's loads of literature on it in the US. In the US, there's tons of data on the basis of which these prices are set, but you don't have that kind of data in the Indian context. And the other part thing that these systems depend on is enforcement. So, this only continues to provide financial protection if you can ensure that hospitals are sticking to the price that that the hospitals are not charging patients in addition to what the government is paying them. So both of these things in the Indian context don't necessarily hold. There isn't good data on costs that can be used to set the reimbursement rates for hospitals. There's also relatively weak oversight of the hospitals. So stepping back a second, so these insurance programs are essentially a very large public subsidy that is being delivered through private hospitals, and this constitutes a major policy shift away from the sort of historical direct public provision of healthcare. You're now paying private hospitals to provide quite complicated healthcare services, and yet, despite a decade of implementation of these programs in various parts of India, there's very little known about how private hospitals perform in these programs. So what I do today, I'm going to talk about a study of a large health insurance program in Rajasthan, a state in India, that is very similar in design to the national PMJ program I talked about earlier. And what I'm going to do is use a massive data set of 6 million insurance claims. This is program administrative data linked to patient surveys. And I'm going to take advantage of this policy reform that happened in December 2017 that changed hospital reimbursement rates. And as I've sort of touched on earlier, these reimbursement rates are a key aspect of the incentive structure of hospitals. And so looking at how hospitals respond to changes in the reimbursement rates allows us to understand something about their incentives and behavior. And essentially what I'm going to establish a few facts about how private hospitals participate in these government insurance programs that were not known before, or certainly that were not known in some systematic way. I'm going to, just to summarize very quickly, I'm going to show you that hospitals manipulate coding in order to increase their revenues. This is this has been documented in the US, and I think, the first evidence that this is happening in India as well at quite a large scale. Second, I told you these programs entitle patients to free care, but I'm going to show you systematic evidence that hospitals are charging patients for care under the program. So care is not, and in fact, free. Thirdly, I'm going to show you some evidence that actually, this might seem like fraud, but part of the reason hospitals are charging patients is because the reimbursement rates that the government set are too low. And so to some extent, this fraud is actually compensating for poor program design. And fourthly, I'm going to show you that nevertheless, that there is a substantial amount of capture of this public subsidy, essentially these payments that the government is making. The idea is that they should benefit patients, but I'm going to show you that actually hospitals capture a substantial share of these payments as profits. And this is especially true in uncompetitive areas. So I'll come back to all of this, but that's broadly what I'm going to talk about today. So the insurance program I study is the BSBY health insurance program, which was launched in Rajasthan in December 2015. And this is a state of about 70 million people. The program, it covers poor households based on government poverty lines. And so at the time of the study, this was about 46 million individuals, so large. Beneficiaries are entitled to free hospital care up to a sort of an annual cap that is an attempt to reduce outrageous fraud. And they can get care at any of roughly 1,000 hospitals, 2/3 of which are private all across the state. And the way it works is that there's a pre-specified list of about 1,400 services that the program covers. And as I was saying earlier, you have these bundled payment systems. So basically the government has a list of 1,400 services and pre-specified reimbursement rates for each service that the government has come up with based on consultations with government hospitals and some members of the private hospital community. And these reimbursement rates are supposed to cover the entire cost of care, whether the patient stays for 2 days or 4 days or gets some, a medicine X or Y. The reimbursement rate is fixed. It's supposed to cover all tests, medicines, and cost of stay so that the care is free for the patient. And in part because, as I mentioned earlier, we don't have very good cost data in India. Nobody knows how much, what the costs are of providing, say, a childbirth at different hospitals in different parts of the country. So to some extent, these reimbursement rates are not adjusted for local costs. They're not based on hospital cost data. They're also not, unlike the US, they're not adjusted for patients' risk. So there's just one flat rate that's paid across the state for each type of service. So just to give you an example, in 2017, at the time of the study, a basic vaginal child delivery was reimbursed at about $50. All of the insurance claims filing and payment and all of that happens to this government IT system, which is where we get all of our administrative data. There's a single third-party insurer, which is a parastatal organization. That's the insurer across the state. And as I mentioned, this program is, the things we find in this program are likely to apply to the national PMJ program, in part because the design is very similar. The reimbursement rates may be different, but broadly the design is similar. So just to give you a sense, I'm going on about the private sector. In this program, what I'm showing you here is the monthly hospital visits or transactions in the program over the course since the beginning of the program in December 2015 through the end of our data. And in the red line is the visits at private hospitals, and the blue line is visits at public hospitals. The vertical red line is the policy reform, the sort of when the government changes reimbursement rates. The whole insurance program was renewed for another couple of years, and so that's what that vertical line is. But what you see is essentially after rapidly scaling up, hospital visits in the public sector remain roughly flat at about 40,000 transactions a month. All of the expansion in utilization is coming from the private sector, which is that red line that's steadily increasing over time. So this is to say that I mentioned earlier, people prefer the private sector. The private sector is playing an important role in this program. It accounts for 2/3 of the hospitals. By the end of late 2019, it accounts for 2/3 of hospital claims and the majority of spending under the program. So it's worth understanding. to fix some ideas about what we are talking about. So this is, these are a couple of photographs of a smallish private hospital in Jaipur district, which is the, so it's about maybe 60 kilometers from the capital of the state. And so the, most of the programs in this, most of the hospitals in this program are these, are relatively small, 2 to 3 story buildings, like you see on the left here. That's the vast majority of them. And on the right is the maternal delivery ward of this private hospital. So if this looks sort of simple to you, then for comparison, here is the public hospital in that same town. There's typically roughly 1 to 2 public hospitals per district in India. So the left is the sort of entryway of the public hospital, and to the right is the delivery ward in the public hospital. So while the first one might have looked basic to you, this is, you see why the private sector might be more appealing to people. It certainly looks clean and feels cleaner. And so while these, so the majority of the hospitals are those smallish private hospitals, a third of the hospitals are these government hospitals. There are some hospitals which are much, much bigger, like this. This is just outside Jaipur city. And this is a large multi-specialty hospital that, so this is kind of the highest level for the private facility, but there are relatively few of these in the program. So what I do here is I use the universe of administrative claims data that was generated by the program. This is something like 6 million observations. And literally, basically, this is data on every transaction under the insurance program between December 2015, when it was launched, and October 2019. And the data, it's not as detailed as American insurance claims data, but it has information on the hospital, whether it was public or private, where it's located, the services that were, for which claims were filed, specifically this, the specific from the list that the government has developed, which of them was provided to the patient, the date of the transaction, some information on patient age, sex, address, and phone numbers. And we put a lot of effort into geocoding both the hospital locations and the patient residence location, so we know where people come from, where from where to where people travel for every visit under insurance. What I do then is link this administrative data to patient surveys. So essentially, using the insurance claims, I identify the most highest volume services and then sample randomly from them to basically select claims from them randomly. And then using the phone numbers in the claims data, we conduct phone surveys with patients roughly within 3 weeks of the claim being filed. So we were getting claims data regularly every 2 weeks. And so we were able to do surveys every week soon after the patient had visited the hospital. And the reason, the point of the phone surveys is it allows us, it gives us a lot more information that the administrative data does not have, including what were the services received, what was the care quality, out-of-pocket charges, which are not in the administrative data because they're not supposed to exist at all, and other things like patient awareness and risk and things like that. And so we conducted these surveys between July 2017 and June 2018, so roughly 6 to 7 months before and after the policy reform that I'm just about to talk to you about. So using this, so the first 2 sections are about the data we use. And so in December 2017, the government revised the hospital reimbursement rate. So I told you there was some 1,400 list of services with preset rates for each service. In December 2017, the government decided to revise the rates for different services. And these amounts, the way the new rates were, the changes were varying magnitudes across different services. And essentially because, these new rates took effect overnight on 13th of December. And, it's unlikely, there's no reason to think that the hospital costs, of providing these services changed overnight. So essentially this policy reform creates this shock to the profitability of different services by different amounts. And that creates a natural experiment that I can use essentially just to sort of simplify. I kind of compare outcomes before and after the reform across a whole range of services, taking advantage of the fact that each of them gets a different reimbursement rate increase. And so this kind of just demonstrates the policy reform that I'm using. So across the x-axis is time in weeks, on the y-axis is rupees in Indian rupees. And so these are, there are about 5 different types of vaginal delivery. So there's a different sort of, each one has a different, is a different thing on the government package list. And so, what you see is these reimbursement rates before the reform. The vertical line is the date of the reform. And then suddenly the reimbursement rates for each of these things changes. As you see, the one in the middle, the green line is the vaginal delivery with forceps. The reimbursement rate for that didn't change at all, but the others changed by different amounts. And what you see is that the rates change both relative, for a service post December 2017 relative to pre-December 2017. But what you also see, if you look at the sort of vertical spaces between these different types of services, there's also a change in, how in the rates of closely related packages. So these are 5 different types of vaginal deliveries, and you see, their relative rates relative to each other also change, and that's what we kind of exploit. So the point of the, what this, as I sort of said briefly earlier, using this policy reform allows us to look at sort of changes in hospital behavior in a way that we can't see in the cross section, and that kind of lets us get at some understand behavior a little bit more. So the first set of results I'm going to tell you about is coding, evidence of coding manipulation. This is essentially, we see these large and immediate changes in service composition. So again, just as before when I showed you the rates, on the x-axis is time in weeks, and on the y-axis is, well, I'll get to that in a second. So what I'm showing you is there are 3 different neonatal care service packages, or sort of, the package is what they call this in the program. So there's a basic neonatal care, specialized neonatal care, and advanced neonatal care, and each has a slightly different reimbursement rate. And so what this graph is showing you is the share of all neonatal claims that are coded to each of these 3 types of service, 3 types of neonatal care. And so what you see is that, for a long time, each of it was about a third of neonatal claims were coded as basic, a third as specialized, and a third as advanced. The vertical line is again the date of the policy reform. And what you see is literally, keep in mind the x-axis, these are data at the weekly level. Literally within a week, the share that's coded to basic and to advanced changes dramatically. So essentially what we're seeing is that the way hospitals code their neonatal care claims between these 3 types of neonatal care changed almost overnight when the reimbursement rates changed. This is just another example using those same vaginal deliveries. There were 5 different types of services. The changes here are not quite as dramatic, but as you see on the top, there's the red line drops suddenly at the time of the reform. So it's essentially, we see this across a whole different, all sorts of services. This is just kind of descriptive evidence that there are these large compositional changes. The other thing is that while we see these large compositional changes in the private sector, we do not see them in the public sector. So on the right hand, this is ear procedures. On the right hand, or maybe that's left hand, is where you see the really big changes. That's in the private sector hospitals, and on the other side are the composition in public sector hospitals. And as you see, there's just not as much. Public sector hospital volumes don't change in the way we see. And this is, this is somewhat relevant because one thing to say is that, while the private sector gets its money, is paid under this insurance program and has an incentive to get paid more under the program, the way public hospitals are set up, they're paid by annual budgets that are completely separate from this program. They have no incentive they don't benefit anymore when they get more people coming in under insurance to them, in Rajasthan at this time. The other thing about this that, so far I've just shown you that, okay, there is this big change and it happens kind of overnight. What I'm showing you here, again, this is just descriptive evidence with one set of services looking at vaginal deliveries. What you see is that the change in the coding is strongly positively correlated with the change in the reimbursement rate. So on the x-axis here is the change in the reimbursement rate for each service, and on the y-axis this is a change in in what shares claims was coded to that package. And what you see is that it's a strong and positive relationship. So essentially what we do, I'm not going to get into the empirical sort of analysis here, but we use I use a difference in differences. Essentially, if a formal analysis across a whole range of, I think, like 18 services, or well, technically 93 services, essentially what we find is that the composition of claims in the private sector increases when the reimbursement, essentially the volume of a service in the private sector increases when the reimbursement rate for that service increases. But we don't see a similar response in the public sector. The public sector, and I won't get into all how to interpret this graph, but that's broadly what the result is, that volumes in the private sector are extremely responsive to reimbursement rates, volumes in the public sector are not. So far I've shown you, okay, there are these big changes in composition and they're strongly responsive to changes in reimbursement rates. So you could say, well, there are three potential explanations for these changes. One could be selection. That is, so all of a sudden, the hospital is like, oh, this new thing is much more profitable, so I'm going to try to select in the kinds of patients who need this new thing. Between, service B is more profitable now than it used to be, I'm going to try to find a lot more patients that need service B. So that's selection. Changing in the kind of patient that's coming in. A second explanation is changes in over or under provision. So they don't, between A and B, they don't actually find ways to attract patients that need B, but they just do more of B because it's more profitable. And so there's no change in what the patient actually needed. The hospital just changed what it did. And then the third explanation could be it's a pure coding manipulation change. So that's like, the type of patient didn't change. What was done to the patient didn't change. All the hospital did was change the way it coded. So it coded between A and B. It started coding a lot more of its claims as package B, because package B is much more profitable right now. And I won't get into all of it, but essentially, I do several things to show that while I can't completely, rule out each of these three explanations, overwhelmingly the evidence, there's strong evidence that there is a lot of coding manipulation that's going on and that's changing at the time of this reform. And probably the most compelling sort of factor to me is that these changes happen immediately within a week of the reimbursement changes, and these compositional changes are happening super fast and are super responsive to reimbursement rates. And it's just really hard to imagine that the hospital can so precisely and so quickly find ways to attract exactly the patients that need these, now more profitable services. But there's also, what's kind of nice with our surveys, I can also show that, provide some other pieces of evidence that it doesn't look like it's selection or over provision. And all of the evidence largely points in the direction of coding manipulation. So broadly, this is, I think, the first, systematic evidence in a large scale health insurance program that private hospitals are manipulating coding to increase their revenues. The second set of results I'm going to talk about is out-of-pocket charges. So, I said that this program was supposed to be free. Patients are entitled to completely free care. The reimbursement rate that the hospital receives is supposed to cover the full cost of stay, tests, medicines, diagnostics, etc. However, in our patient surveys, and these surveys are conducted with patients for whom a claim has been filed, and it's the survey, we talk to them within 2 to 3 weeks after they went to the hospital. And what I show you here is, on the x-axis is the payment in rupees. Across a range of different kinds of services, we find substantial out-of-pocket charges. The light gray charges are what they pay directly at the hospital, and then the dark gray are for tests, medicines, or diagnostics, like just outside the hospital, but associated with that same visit. And so, almost half of all patients are paying, and the average patient payment, although it varies across service, the average payment is about $30, which doesn't seem like a lot, but keep in mind the annual, at most a household is allowed to spend $5,000 in a year. Another way to think about it is that this program is targeting the poorest households in Rajasthan, many of whom, live on just a few dollars a day. So this is a large amount for them. And another way to put this in context is that the out-of-pocket charges that we're seeing constitute a 33% markup over the reimbursement rate on average across these services. Okay, so this is not actually small amounts for these people in the context of this program. And the other thing, as I said, was that this is out-of-pocket charges by patients that have visited a hospital that is in the program. These are eligible and enrolled patients. They visited a hospital in the program. The hospital has filed a claim for their visit and been reimbursed by the insurer. And so, this can't be explained by other problems like this. The person wasn't enrolled, or didn't go to the right hospital didn't go to a hospital that was covered in the program or whatever. This is direct proof of hospital charging behavior for care that should be free. The big question is, why do hospitals charge? So there are two, broad explanations, and I encountered this in policy circles in Rajasthan quite a bit. One is that, and this is what hospitals will often say to you, is that they are charging patients to compensate for low reimbursement rates. In other words, the cost, let's take a basic vaginal delivery. The cost of providing vaginal delivery is 5,000 rupees. The government's only paying me 3,000 rupees. It's not enough. The only way I can do this and cover my costs is by charging patients the balance, the remaining 2,000 rupees. And that's what hospitals say. Well, they won't tell you they charge out of pocket, but if you can't, but that's what they'll say others are doing. Okay, so that's one explanation. The other explanation, which you often see, for example, in the media, and something that I thought was happening a lot when I started working here, is that hospitals are just exploiting patients and charging whatever they can. That hospitals have, because of market power, there are frictions in these markets. Patients don't always know what they're entitled to. In some areas, there's only one hospital. It can charge whatever it wants. It has monopoly power, and so these out-of-pocket charges are essentially have nothing to do with the reimbursement rates or costs. It's just hospitals exploiting patients. Okay. So these are the two competing explanations, and it's really, sorry, my notes don't quite make sense there, but the idea, disentangling these two explanations is really important for policy design, because if the problem is that the rates were too low, then you need to think about increasing your reimbursement rates. If the problem is that hospitals are just overcharging, then you need to think about monitoring hospitals better. And, we're talking about 1,200 hospitals across the state. It's substantial resources towards monitoring would be needed, or maybe it's a little bit of both. And this is extremely difficult to disentangle in the cross-sectional data, and I'm certainly not from people's reports. So what I do here is use how the effect of this policy reform that increased hospital reimbursement rates to understand which of these two is going on, and how that happens is. So if it were the first thing, if it were that hospitals are just, making up the difference by charging patients because their costs are higher than the reimbursement rates, then, we think that, hospitals' costs are unlikely to change discontinuously on the December 13th, but they suddenly get paid a lot more. If they were only charging patients to cover, make up the balance, when the government pays them more for a service, they should just charge patients less. So using that same example, they were getting 3,000 for this vaginal delivery that costs them 5,000. Let's say the government increases the rate to 4,000 now. So now the hospital only has to make up the 1,000 rupee difference. So I should see that for that 1,000 rupee increase in payment for reimbursement rate for vaginal delivery, the hospital, there should be a similar 1,000 rupee decrease in what hospitals charge patients for vaginal delivery. Right. So I don't need to know what the hospital's costs are. I can just look at what happens to what they charge patients when the reimbursement rate increases. So if it's the first explanation, I should see an equivalent decrease in out-of-pocket charges for every increase in reimbursement. But if it's the second explanation, hospitals are charging whatever they want, because they can. In this case, when the government increases reimbursement rates to the hospital there's no reason the hospital has to pass that on to patients in any way. It can keep charging what it was before. And so if it's the second explanation, we should see either a small or no decrease in out-of-pocket charges for every increase in the reimbursement rate. Okay, so this is kind of what the logic we use. So I'm going to show you. So this is a sort of my differences estimate, but essentially how you should interpret this is that on the y-axis is the change in out-of-pocket charges, and what it's showing is for every 1 rupee increase in the reimbursement rate paid to hospitals, how much does patient out-of-pocket charge decrease? And what this shows you is for every 1 rupee, or let's say for every 100 rupee increase in the reimbursement rate that is paid to hospitals, out-of-pocket charges decrease by 50 rupees. So it's like for every 1 rupee, you get a 50 paisa decrease in out-of-pocket charges. And this is a large and statistically significant decrease. So, there's a lot more here, but I'm just going to sort of briefly summarize what I find about the out-of-pocket charges. Essentially, firstly, importantly, increasing the reimbursement rates for hospitals does decrease what they charge patients significantly and substantially. So Paying the hospital more results in hospitals charging patients less. But what this implies actually is that hospitals capture the remainder. So hospitals are capturing about half the increase in payment by the government, right? The remaining 50 pesa. And I find that this, hospital capture is greatest in the least competitive markets. So, I was sort of explaining that briefly earlier. It's precisely where in markets that are not very competitive, where the hospital doesn't face much pressure to reduce its prices, that's exactly where, when the government increases reimbursement rates, hospitals don't pass it on to patients in the form of lower out-of-pocket charges. And, I showed some, you might think, well, maybe hospitals do this, pass this on to patients in other forms, like they improve the quality of care, or, increase the length of people's stay, or, and I don't find any evidence of that. Then lastly, I'll just touch on this very briefly. Another thing I find is that when the reimbursement rates increase, real service volumes, not setting aside all that upcoding stuff I was talking about earlier, service volumes do increase. And that's kind of consistent with when the government pays a higher rate for a service, in this case, healthcare, private hospitals are willing to supply more of it. Okay. Now, just to briefly summarize and tell you what all of this means, or suggest what all of this means. So I've shown you, the first thing I showed you is that I think this is some of the first systematic large-scale evidence of private hospital non-compliance with government health insurance programs in India. And I showed you both that there's evidence of coding manipulation by hospitals, as well as charging out of pocket for care that is supposed to be free. And so, this is not a rocket science implication, but needs to be said that simply mandating that care should be free does not ensure it is. Without monitoring and enforcement, hospitals, especially private sector hospitals that are sort of profit motivated, are going to bend the rules to increase their revenues. And that it means upcoding, which costs the government, and it means charging out of pocket, which costs patients. The second thing I showed you is that when you pay hospitals more, when the government increases the reimbursement rates it pays hospitals, hospitals reduce what they charge patients. And what this implies, going back to the question about why do hospitals charge, this implies that to some extent some hospitals were compensating for rates that were too low and charging patients the balance. And so when the government increased it, they charged less. And so what this, what looks like fraud or non-compliance, it's worth understanding. It's the nuance of it is that to some extent hospitals are compensating for poor program design, for reimbursement rates that were set too low. And what this implies is that if you just, I hear this often in policy circles, well, then let's, go crack down on these hospitals and not, stop them from charging patients. Well, to the extent that hospitals were charging patients to compensate for low reimbursement rates, if you crack down on hospitals and don't let them charge anymore, it may actually drive them out of the program because they're not going to be able to cover costs. So you need to be, cracking down without thinking harder about how to set reimbursement rates better and in ways that cover costs may actually drive hospitals out of the program and actually worsen patient welfare, right? Because as I showed you, the people overwhelmingly prefer private hospitals. The third thing I showed you is that, nevertheless, despite what I just said, when the government pays more, hospitals capture about half that increase. So when the government increases its reimbursement rates, half of it goes through it to patients in the form of lower charges, but half of it stays with hospitals as profits. And hospitals are particularly likely to capture this subsidy, the reimbursement rate increase, in areas that are uncompetitive. Sort of the converse of what I just said, increasing monitoring without looking at rates might drive hospitals out, sorry. Similarly here, but increasing reimbursement rates without also monitoring hospitals may end up just being a transfer to the hospitals. So if the government sees these out-of-pocket, hospitals are saying that they are charging out of pocket because the rates are too low, let's just increase rates. Well, a chunk of that money just ends up going to hospitals. That's what we find. The sort of second implication of this, one that I think about a lot, is that competition or market structure is not usually taken into account in Indian health policy, but especially as you're thinking about contracting with the private sector, some of the results I'm showing here show, and it's consistent with broader literature in economics, that competition can shape how well you're able, how the effectiveness of contracting with the private sector, and it can shape the extent to which public subsidies end up benefiting the beneficiaries, reaching the beneficiaries, right? And that, like in this study, I showed that the subsidies reach beneficiaries more in more competitive markets. And so in a sense, what this means is also that, like, competition in this context where the government doesn't have a ton of ability to see all these hospitals that are spread all over the state, to some extent, we find that competition helps discipline, and it can kind of be a supplement to monitoring. And sort of the corollary of that is that one policy implication might be to encourage competition in these programs. And in fact, not just by the private sector, actually, I suspect that encouraging competition through a strong public sector would be quite beneficial as well, if that's doable. And then the last thing is, like, sort of a related point is that, given this, if there are limited resources for monitoring, the government might especially want to focus on areas where less competitive markets. That's my, that's all I have for you today. I hope that wasn't too fast. And if you have, I sort of gave a general and broad overview, but if you have questions, feel free to email me. There's a more technical paper behind all of this. Thanks.
Great. Thank you, Radhika. And everyone here, feel free to add questions in the Q&A. And some people weren't able to join live had sent in questions. So just to go back to some of the points that you raised and provide background for people that may not be as familiar, you mentioned this interesting behavior of the private sector hospitals in multiple respects. Some people, in other systems, there might be a distinction, enforced or not, between for-profit and not-for-profit or NGO. What is your comment about that in the India context?
Yeah, I think I should remember also pointing out that the private sector in India is extremely fragmented. It's tons of what sometimes I call mom and pop hospitals, very small, whole range of sizes, but a lot of them are very small. There is not a census of hospitals. I don't think anybody knows, exactly where all the hospitals are. A lot of them are not registered in some official way. So I don't have any, I don't have hard numbers on the share of hospitals, the share of private hospitals that are NGO or nonprofit versus for-profit. So I'm not sure if there may be some national statistics on that. But my sense from, time spent in these areas is that the majority are actually for-profit. Nonprofits are a small share of but in my study, they fall into the category of private hospitals.
Thank you. And so another question that often comes up is the extent to which individual hospitals might be cost shifting among their patient population. So do you want to share anything about the percentage of their patients that are under this program versus other self-pay and comment on that?
So yeah, no, it's a good question. It's a good point, and relevant. Again, there is no data on this. There's no data on the total volume of patients at hospitals. And, I've asked hospitals and it varies a lot. So I think for the smaller hospitals, the insurance patients are a larger share of their overall patients. And this is also shown why those are the hospitals that are most likely to impanel in the program. I think, the vast majority of their patients come in under insurance. But the larger, as you get larger, it becomes a smaller and smaller share of the total patients at the hospital. In terms of cross-subsidization, yeah, I don't think that should affect, what I'm estimating a whole lot here, but I suspect there's to some extent that happens in every hospital, because costs, can't exactly be linked to a patient.
Great. So you had also mentioned that one way to address this in policy is to strengthen the competitiveness of the government hospitals when you're thinking about market competition. So maybe you could comment on if you have any recommendations about that. I mean, why patients are choosing, why the market structure arises the way it does. Is the market structure itself going to be endogenous to these kinds of policies? And finally, maybe how you're actually measuring competition in this context.
So, I mean, it's funny because I closed by saying, encouraging competition would be great and including through the public sector. I suspect, though it's not a foregone conclusion, but it has the potential to discipline the private sector if you have a high quality, low price public sector. But on my second slide, I said that part of the reason these programs have contracted the private sector is because the quality in the public sector has been really bad and it has been extremely hard to reform. So, a major issue with the public sector is, I guess I suspect there are two. One is, the incentives for the staff in these public hospitals. And I don't just mean that, there's some part of that might be, look, it'd be nice for them to get bonus payments, have some, get some reward, financial reward when they do better. Most of them they're all salaried people. But I also mean sort of, intrinsic motivation, like recognition. And, there's just not a lot of that. And I think that contributes to things like absenteeism and shirking and things like that. And the other is, maybe it's related, but is more autonomy, more control, more resources given to these, But I don't, there have been studies that, for example, have tried to, absenteeism at public hospitals or health facilities is a huge problem. So there have been studies that try to work with the government to establish, check-in machines, like little thumb scanner machines to enforce attendance. And essentially the thing worked while it was being enforced, but it stopped being enforced because it was just politically infeasible to do anything. If someone stopped coming in, it was infeasible to actually fire them or do anything with this. So I think, I think that's sort of, how to tackle the political economy problems before you can actually reform public hospitals is a big and open question that I don't have answers for. But yeah, I think it would be a strategy. There's some 600 districts in India. There, let's say, at most there are two public hospitals per district. That's like 1,200. If the government could focus on just really improving the quality of those, I think that would go a long way. On the measure of competition, actually, so there's part of the reason competition doesn't get discussed in India at all is because it's very hard to measure it. Because if you don't, it's like, there's certainly no public, if you don't even know the number of hospitals and where they are, you certainly don't know their service volumes, right? Which you would need to understand to figure out market share. But so what is nice about these programs, and this is the sort of big thing here, is that these insurance programs are collecting super rich real-time data on hospital visits, and so you can see exactly where the hospital, with some effort in our case, you can see where the hospitals are. You can see their patient volumes under insurance, not outside insurance, and so essentially we use the insurance claims data to calculate Herfindahl indexes for each service at the district level. But yeah, you can certainly get more sophisticated than that. But yeah, I think it'll be, I don't know if there are plans to make there's so many of these insurance programs across India right now. If they could make this data more widely available, it would be actually possible to start looking at things like, what are the best definite ways of measuring competition in these areas.
Great. So let's call if any listeners have any questions, put those in the Q&A. I'll go back to some of the previously given ones. So one thing you mentioned about the interaction of contracting out and competition, I'm wondering about your recommendations beyond what you mentioned. So for example, should the government contract out only in competitive markets?
I think probably not, because even in less competitive markets, then it just means these private hospitals are providing an important service, right? So if you want people to have access to at least some hospitals, then it seems like you need to pay them. But I guess like one implication of what I'm showing is that maybe those are precisely the places where you need to do more, be talking to patients to understand whether hospitals are charging, doing a lot more monitoring of what the hospitals are doing. But I would not say that you should not contract there at all, probably.
And of course, we're currently in the pandemic moment. I wonder if you want to comment, and you've also done research on the impact of the pandemic in India and all of the discussion about how to build back better subsequently. I don't know if part of that is helping to leverage technology for the monitoring that you talk about, or to focus on some of the gender disparities in this. Just an invitation for you to share with us some of your thoughts about going forward, what policy might do to address these issues.
I mean, actually, one of the things I thought about through COVID. Okay, so in Rajasthan, the insurance program ran into problems right before COVID, and so was not particularly functioned during COVID, which is tragic. I think precisely when people are going through a major financial crisis. I think in other parts of the country, there seems to be some evidence that these insurance programs provided a really important safety net during the, just because COVID happened doesn't mean that you don't get into, you don't have other medical emergencies. There were issues with private hospitals, for example, not wanting to, or even public, but mostly private, not wanting to take patients because of fear of COVID and things like that. But to the extent that, one aspect of, having these programs at least helped to some extent protect people through what was already a major financial crisis. I think another thought I had at the time of COVID was actually how, as much as I study private hospitals, and I think they are an important part of the system, well, certainly in India, they already are an important part of the system, so they weren't studied. But, in a crisis like COVID, the public health system became extremely important, in part because, when you have this like super fragmented private sector all over the country, you don't have a good handle on where it is, what the numbers, and the government cannot control it in the way that the public health system is this massive resource that the government was able to sort of redirect to its needs during COVID. And so it just like reinforced for me that the how a strong public health system in context like India actually can be important in situations like this. Yeah, I think going forward for these insurance programs, I think there's been a lot of learning over the last decade. I'm showing you, I'm talking about all the things that are not quite working, but these programs have improved a bunch. I think one aspect I think that needs to be focused on is really building in accountability, building in better monitoring. I think what we did, for example, was use phone surveys to get some sense of how hospitals were performing. This could be done by governments. I think this is an issue in India and social programs more generally, that like there are ways to improve the functioning of the program by building in some accountability, by checking in with the final beneficiaries if they're getting what they're supposed to get. And it's not that complicated or expensive to do, and that would be something that could really strengthen these programs, getting some voice of the patients themselves into it. I'm hopefully starting some new work on, I think, this hospital monitoring question is a big one. And as these programs expand and less money being spent on them increases, like figuring out, I sort of touched on this, it's, hospital monitoring could have sort of heterogeneous effects depending on why the hospitals are doing what they're doing. It's not straightforward. And there's not a lot of work yet being done, like, to my knowledge, on how to design these hospital monitoring, what the effects of it are, both positive and adverse. So I think that's going to be an important area going forward, and maybe something I'll be working on. You said something about gender, which is, I think, so Pascaline and I have this paper that should be coming out as a working paper very soon, actually showing that, there are huge gender disparities in these programs. Females are, especially amongst the very young and the elderly, females are far less likely to be using insurance than males are. And we do some work to show, this is all using that administrative data, we should do some work to show that this is partly because households are gender biased. The program is not entirely free. Households are much more willing to spend on males than they are on females. And so there is this, these programs are being rolled out with the hope that they will reduce inequalities in healthcare access and therefore healthcare outcomes. But that's not part of what we're trying to show with our gender paper is that that's not a foregone conclusion, that, simply making care available does not actually necessarily ensure equality. We don't have any data on cost, for example, but I can see, just looking at the administrative data, there are certain geographic areas which tend to be more low caste, or at least scheduled tribe, that have have limited access. So I think this whole, are these programs actually meeting the objective of increasing access, ensuring the most vulnerable have access to care? That is not entirely clear, and needs to be, that that should be a priority, I think.
Great, thank you. We actually had a question related to that, so maybe I'll ask this as the final question. The attendee says, thanks for your insightful research. Do you find any attempts from the governments, NGOs, or other organizations at the grassroots levels to fill the gap between the rich and the poor in accessing hospital care, such as a private hospital?
Yeah, I think there's, I think this is exactly, this kind of insurance program is precisely trying to do that. I think because and the same with the national PMJ program, it targets the lowest income households in the country. It's exactly trying to make sure that those households have access to high quality care beyond the public health network, public hospital network that already exists. But as I show, so if these programs are still charging out-of-pocket payments, that's still going to exclude the poorest households. So the gender bias stuff that we work on shows that women are being somewhat left out. So there's still not the poorest aren't always being reached, but I think this program, besides the insurance programs, the government is also investing in its public health network. It's establishing more of these sort of these strong. It's investing more in its primary healthcare network. Supposedly improving the quality at its public hospitals, but we'll see how much that's true. But these are the main policies the government's has in place: the health insurance and its public health network, in order to reach poor households.
Well, great. Thank you so much, Radhika Jain, and thank you all for joining us today. Please look at the website later for links to her other research and join us for later webinars.